Good evening, everyone. Thank you for attending our quarterly trigeminal neuralgia support group meeting. Tonight, I thought I would present a kind of a comprehensive process of how one walks through the process of evaluating a patient for trigeminal neuralgia. And we'll take a look at kind of the detailed history taking, evaluation of the symptoms, the how we classify face pain, and then in terms of the treatment plan, I'm going to talk about the process by which we would walk a patient through a microvascular decompression, which is the most common of the treatment options that we typically do for trigeminal neuralgia. So a lot of this is kind of what I think about, and when I go through my mind when I'm seeing a new patient that comes into my office with face pain. So the goals of any seeing any kind of patient with face pain is to try to make a diagnosis first and foremost. Are we dealing with true trigeminal neuralgia, and we'll define what that means. Are we are dealing with some other type of face pain? I'm going to talk about the nuances of the history taking and how it's really important to get a detailed history for a patient with facial pain, because trigeminal neuralgia can almost always, the diagnosis can almost always be made on the history taking, as opposed to the examination or the MRI scans. The third, we're going to understand the clinical symptoms, but the classical symptoms for trigeminal neuralgia versus other types of face pain. We're going to talk about expectations for the alleviation of symptoms, and we're going to talk about how we would get all this to happen through a microvascular decompression as safely as possible. Okay, so first, the first thing that all physicians are trained to do is to get the story from the patient. It's when you're diagnosing face pain, and particularly trigeminal neuralgia, it's incredibly important to get a detailed history, because there's going to be a lot of clues in the history that you obtain from the patient as to whether this truly is trigeminal neuralgia or some other type of face pain. So we want to know the type, nature, and quality of the pain. So is the pain something that comes and goes? Is it present all the time? Is it sharp pain? Is it burning pain? Is it an achy pain? You know, how would patients, kind of in their own words, describe the pain? Is the pain is the pain something that's alleviated by certain activities and actions, or exacerbated by other activities? We want to know what the nature of the pain is. Now, oftentimes when the patient sees us in clinic, the pain has been there for potentially a number of years. So it's just as important to find out what the pain was like when the patient actually started having pain. So let's say the patient has pain for 5 years. I want to know what pain is like right now, but I want to also know what the pain was like when it first started, because what we're going to learn tonight is that the pain often evolves over time, and if you don't go back to find out what the pain was also like at the beginning, you may be missing some important pieces of information that will help you make the diagnosis. I think it's also important to clarify the definitions of what we're asking, because sometimes I'll ask a patient, you know, do you have the pain all the time? And they'll say yes, you know, but what they really are meaning and saying is that they have the face pain, let's say the shock-like pain, and it's very frequent. They may have multiple attacks per hour. And they interpret that the frequency of which they're having these attacks as, I'm having face pain all the time. Whereas what I'm asking for is, are you having pain every minute and second of the 24 hours. Like, is there any part of the day that you don't have pain? And then oftentimes the patients will say, well, I have a lot of electrical shocks per hour, but if I sit there, I'll have 5 minutes, 10 minutes without pain. So it's important to clarify the definitions. What what we interpret as pain all the time may not be what the patient interprets as pain all the time. And then again, I think it's important to take the patient back to the very beginning, because oftentimes the description of pain during the first 6 months or year that the patient has a pain is more useful in determining trigeminal neuralgia than when they're presenting 5 or 10 years later, because the pain changes in terms of its quality, and it can change to a more confusing picture. But the pain that they usually have at the beginning is much more classic. Also, in the history taking, we want to ask specifically about prior infections. There are some infections that we're going to learn about tonight that cause face pain. We want to know about prior procedures or trauma. So procedures specifically on the face. Did they have a facelift? Did they have surgery on their neck? Did they have dental work? Did they have any type of procedure on their face, including a procedure for face pain? We also want to know, were there any traumas? Did they hit their head, in a car accident? Did they were they assaulted and had hit on the side of the head? All those go into the history taking to help us determine whether this is true trigeminal neuralgia or not. And oftentimes, family members are useful to provide input. Sometimes by the time we're seeing the patient in the clinic, they're on a substantial amount of medication to alleviate the pain, and that can often make the patient's responses a little bit more cloudy or a little bit slower in terms of their cognitive function. And it's often the family members that can remember much more distinctly, what the pain was like when it first started, because the patient may not be the best historian. When we're talking about pain, we often try to find a classification to categorize pain. And one of the most commonly used classifications is the Burchell classification by a neurosurgeon named Kim Burchell, who practiced for a number of years focusing on facial pain. And Dr. Burchell's classification was designed to help physicians categorize face pain into very specific categories, so that it made it easier to determine what the best recommended procedure was for each of these patients. So I wanted to take a minute or so to talk about Dr. Burchell's classification of pain that appeared in this publication in 2003. So he essentially divided face pain into 7 different categories. And I think it's important to kind of walk through these categories. So the first 2 categories are actually trigeminal neuralgia. And there are 2 types. You'll see on the slide here a type 1 and a type 2 trigeminal neuralgia. So type 1 trigeminal neuralgia is face pain that is predominantly episodic electrical shocks. So the patient will have a series of electrical shocks, and but then it'll dissipate, and they'll have periods where they either won't have electrical shocks, or they may have some residual achy pain. But the intermittent pain is the majority of the pain. The second type of trigeminal neuralgia, which you'll see in the slide here, is what's called type 2 trigeminal neuralgia. And in this scenario, the patient has both constant pain and perhaps electrical shocks, but the constant pain represents more than half of the patient's pain. So if a patient comes in and they say, I have constant pain plus electrical shocks, then I'll ask them, which is more? What are you seeing more of? And if they say, I have 75% constant pain and only 25% of my pain is electrical shocks, they would be categorized as type 2 trigeminal neuralgia. If they come in and they say, 90% of my discomfort is electrical shocks and only about 10% is a little bit of achy pain that is between these electrical shocks. Then they have type 1 trigeminal neuralgia. Interestingly, most patients that have type 1 trigeminal neuralgia over time, it may evolve to type 2 trigeminal neuralgia. So usually when you see somebody with type 2 trigeminal neuralgia, they've had it for a number of years at that point. So those are the first two categories out of the 7. Let's talk about the next category. It's trigeminal neuropathic pain. And this is different than trigeminal neuralgia. And the key word there is neuropathic as opposed to neuralgia. And in trigeminal neuropathic pain, this is pain that you develop in the face secondary to some trauma. So you hit your head in a car accident, you were assaulted. There's some trauma that injured the nerve and maybe caused some scar tissue to develop around the nerve, and that causes this trigeminal neuropathic pain. So the key in the history taking there is that they'll report some sort of trauma. It may be accidental trauma, but they'll report the trauma there. The next category is trigeminal deafferentation pain, and this is pain that can develop from prior, attempted treatments for on the trigeminal nerve. So if you've had a prior rhizotomy or you had prior radiation treatment to the trigeminal nerve, sometimes the nerve can heal with some scar tissue in place, and that can cause this deafferentation type of pain. You'll see the last 3 categories there. You can have pain from multiple sclerosis, and that's pretty classic history because the patient will report that they also have multiple sclerosis in addition to face pain, and we can see on MRI scans multiple sclerosis lesions, or these little white dots that show up on the MRI scan that are pretty classic for multiple sclerosis. Post-herpetic neuralgia, that's a viral infection. It's the same virus that causes chicken pox or herpes zoster. And you can get a viral infection along the face, in which the virus invades the trigeminal nerve. And this can cause kind of a chronic type of pain that can mimic trigeminal neuralgia, but it's not trigeminal neuralgia. And then the last category at the very bottom of the slide is atypical facial pain. That's pretty much everything that doesn't fall into the 6 buckets above. So again, going back to this slide, 7 different categories of face pain. The top 2 are trigeminal neuralgia. And I think it's very important to figure out the category of this type of pain because we would offer specific treatment options such as a microvascular decompression for the first 2 types of face pain. But a microvascular decompression doesn't necessarily have a high yield in treating the other 5 types of face pain. So we've talked about the history. Let's talk about symptoms for a bit. So in clinic, we want to, again, understand the nature, quality, frequency of the pain, but we also want to know what triggers pain. So oftentimes, a patient will say, if I sit there and don't talk or move my mouth, I don't have the pain. But if I talk, I get pain. If I drink water, I get pain. If I wash my face or brush my teeth or have wind blow on my face, I get pain. Those are all triggers, classic triggers of trigeminal neuralgia that often we see with trigeminal neuralgia, but you don't necessarily see with other types of face pain. So understanding the symptoms is important to elucidate the type of pain that you may have. We also want to know what makes the pain better. Specifically, did it respond to some of the classic trigeminal neuralgia medications like carbamazepine or gabapentin? Interestingly, if a patient does have trigeminal neuralgia or a face pain that responds to these type of medications, that's a very good sign that the surgical procedures would work. Mainly because the fact that the patient responds to the medications gives us a good indication that we are dealing with actual trigeminal neuralgia. If they didn't have trigeminal neuralgia, we wouldn't necessarily expect the trigeminal neuralgia pain medication to work. But if it does work, then that actually reinforces and strengthens the diagnosis of trigeminal neuralgia, which means the microvascular decompression procedure has a greater chance of working than otherwise. We also want to know the parts of the face that are involved with the pain, and this is a little cartoon, a little profile view of the face. You can see on the face there are 3 parts of the face. The trigeminal nerve is the 5th nerve, so we're dealing with Roman numeral number 5, which is the V, and we number the nerves as V1, V2, and V3, depending upon the area of the face that is innervated. So in general, V1 is the area around the eyes. You have 1 trigeminal nerve on each side, so it'll each nerve will innervate the face up to the midline. V2 is the nerve distribution that innervates the cheek. So between the mouth, the edge of the mouth, and the eye is V2. And V3, I like to think of as the jawline, the mandible. So we want to ask from the patient where the pain is located. V1 is less common than V2 or V3, but just for documentation purposes, we want to kind of know which 1, 2, or 3 of these regions are involved. Now, as part of the symptom analysis, we will actually ask other questions to, like, how far back to the back of the head does the pain go? And some patients will report the pain completely along the back of their head and in the back of the neck. And the challenge there is, if you look at this profile cartoon with the V1, V2, and V3, you notice it's the front half of the head. You're not seeing the back half of the head or the neck. So if the patient reports pain in the back of the head here, that's not trigeminal neuralgia. That may be occipital neuralgia. But asking them how far back the pain extends gives you a good indication whether you are dealing with true trigeminal neuralgia or some other type of face pain. We also want to know, does a pain cross the midline? We have a trigeminal nerve on the right and on the left, and each innervates the face up until the midline. So if anatomically, the nerves do not cross the midline. So it can be more confusing if a patient comes in saying, I have face pain starts on the right, but then crosses to the left side and goes to the left ear. Anatomically, that's very hard to explain because it really doesn't give us a good sense of how that could be happening from a neurologic standpoint. And the last set of symptoms we want to sort out is there are other types of pain, face pain, including pain with electrical shocks, that can mimic trigeminal neuralgia. So you can be confused here. Patients and physicians can be confused. The first is something called glossopharyngeal neuralgia. It's pain in the nerves that innervate the back of the throat and the tonsils and the deep ear. So if you have glossopharyngeal neuralgia, there is no superficial face pain. It's just pain in the back of the throat where your tonsils are, and that pain hurts when you talk or move your mouth. So it's very important to differentiate between trigeminal neuralgia and glossopharyngeal neuralgia. The second diagnosis that can be somewhat confusing is called geniculate neuralgia, and that is pain from the deep ear down by the eardrum. So the challenge is you can get ear pain from this geniculate neuralgia. You can get ear pain from glossopharyngeal neuralgia. And when we go back to this cartoon here, V3 does involve part of the ear. So you could get ear pain from trigeminal neuralgia. So you can see how that can be a little bit of a challenge in terms of identifying which type of pain syndrome that someone may have. And in fact, there are a few patients that can have more than one of these pain syndromes. And I've had a couple patients with trigeminal neuralgia and geniculate neuralgia. It's important in the history taking and the symptoms to figure out if there's more than one thing going on at any given time. So I want to talk a little bit about the common trigeminal neuralgia, what we call the prototype trigeminal neuralgia patient and symptoms. The pain is described as a sharp electrical lancinating pain, so like a shock-like pain that comes and goes with the appropriate triggers that we just discussed. It usually responds initially to medication. What does this mean? This means that if you start a patient on carbamazepine or gabapentin, they should have a pretty high chance of having a good initial response. And that usually means that the pain medications that they're getting will work. So intermittent lancinating pain, the triggers and respond initially to the pain medication. The pain picture typically evolves over time in these patients. So the classic story is the pain usually develops initially very infrequently. A patient will describe pain as once or twice a month initially when it first starts. They're not even requiring any pain medication. Then over time, the pain becomes more frequently. They start seeking out some pain medication to manage the pain. The pain medication usually works initially, and then over the course of months to years, the patients required increasing doses of the medication to manage the pain. What we also see over time is the time interval between pain episodes shortens. So what used to be, I have a few pain episodes a week, now a few a day, to now multiple times a day, to now 30 times a day. So the pain episodes become more and more frequent. So we talked about the virtual classification. So we're going to really focus today on the first two categories, the type 1 and type 2 trigeminal neuralgia, when we look at management of this disorder. One quick comment on before we talk about the microvascular decompression and kind of the process of walking our way through that is the side effects from medications for trigeminal neuralgia. So the standard treatment is to always start a patient on medical therapy and only consider a procedure if the medical therapy is failing. And so patients generally respond very well to medications, at least initially, but over time requiring increasing doses of medications to manage the pain. At higher doses of these medications, it's possible that patients get side effects, and these are going to be concentration issues, kind of cognitive slowing, balance issues, dizziness, really feeling sluggish most of the day. Those are all classic side effects of trigeminal neuralgia medication. And it turns out, at least in my practice and observation, patients are more likely to seek out a procedure such as a surgical microvascular decompression if they have trigeminal neuralgia. They're more likely to seek out a procedure because of side effects from medications than from actual breakthrough pain. So a good half of the patients that we see will say, yeah, pain's reasonably good controlled on the medication, but I'm just so sleepy, I'm not productive, and I want to have a procedure done so I can get off these medications. So now we're going to kind of walk through the process of a microvascular decompression, for everything from doing the preoperative prep work on the patient to starting the procedure to the actual procedure itself and then finalizing the procedure. So a microvascular decompression, as many of you likely know, is related to a blood vessel pushing on the trigeminal nerve. So it's pounding on the trigeminal nerve each time your heart beats. And the microvascular decompression surgery is designed to put a small cushion in between the blood vessel and the nerve. And that's why it's called a decompression procedure. The microvascular decompression is the procedure that has the best durability, meaning best long-term, permanent, lifetime cure compared to the other procedures. And that's why it tends to be the procedure of choice in young patients or patients that are otherwise good health that have many years in front of them, because We want to do a procedure that's going to eliminate the pain, but have it be a permanent elimination of the pain. We don't want to be in a situation where the pain comes back in a few years and then we're back to square one. So let's walk through a typical process for a patient undergoing a microvascular decompression. Um, I think the first process in clinic, before you even schedule a patient for a microvascular decompression, is to talk about the expectations of the surgery so that everybody, including the patient and the family, are on the same page. So some of these are pretty basic, as you would imagine. How long is my surgery going to be? Who else is involved in the surgery? What are their roles? Do I need to go to the ICU because it's brain surgery? Or if surgery goes well, can I go to the regular floor? When can my family see me? When are the visiting hours of institution? How long will I be in the hospital? Is this I go home the next day, or do I need to stay several days? What milestones do I need to achieve in order to leave the hospital? I need to be, walking around the hallway, getting to the bathroom and tolerating regular food to get out of the hospital? What is the expectations there? Do I need to have any restrictions when I get home? Can I be by myself? Do I need to have somebody watching me 24/7? Are there any restrictions on diet or activity or even washing the head? Those are important to kind of classify up front. It's also important to understand what medications will I need to be on once I leave the hospital. And this is an important question because, as you remember, many of the trigeminal neuralgia patients are on medications and for their pain. So my general practice for that is to keep the patient on their same medications for about a week after the surgery. And then once they experience that they can be pain-free after the procedure and a week goes by, then you can taper off the medications and get the patient off of them so they don't have the side effects. I don't like to just stop at the medications the day of surgery because there can be a lot of inflammation and irritation from the surgery. And the last thing the patient needs is some anxiety of not knowing where their trigeminal neuralgia pain medications are located. But typically after a week or so, if they're satisfied with the fact that they don't have any residual pain, then it's fairly straightforward to taper the patients off of the medication. And then last, I need family around to watch me when I get home. Can I be left unsupervised? And the answer to that question is no, you don't need family, and typically can be left unsupervised if things go well with the surgery. So some preoperative tests are extremely, extremely helpful when you're dealing with trigeminal neuralgia. The first radiological scan that we're typically associated with is a CT scan. These are not able to provide enough detail to see the trigeminal nerve. So a CT scan is only very, very rarely going to show you a problem that you need to address. The second type of scan is an MRI scan. It's generally the first scan that the patient has for trigeminal neuralgia, because we know now to go straight to that scan instead of the CT scan. There are very specific MRI sequences, meaning series of pictures that you want to get for trigeminal neuralgia. If you're dealing with a GE, a General Electric MRI scanner, it's called a Fiesta sequence. The name just is an abbreviation of some first letters of a longer name for this process. So I don't think it's important that you have to really, be able to spell this or understand this, but just know that there are special MRI sequences that allow you to really look at the nerves and to see if there are any blood vessels that are pushing on the nerve. If you're using with the Siemens MRI scanner, it's generally termed the CISS, C-I-S-S sequence. And that, like the GE Fiesta sequence, is just to give you a clear-cut view of the blood vessels that are in and around the trigeminal nerve, because those are usually the culprits that are causing the problem. The last test that some patients come in is what they call a nerve block. They'll say, I got an injection and the pain went away for a week or so or a few days. That's actually not only beneficial for the patient in terms of pain relief, but it also tells us as the neurosurgeons that if you block the trigeminal nerve and the pain goes away, that's pretty compelling evidence that the trigeminal nerve is the culprit here. Nerve blocks are like Novocaine at the dentist's office. They provide relief for a period of time, for hours and days, but not long term there. So if we talk about setting up a patient in the operating room for a microvascular decompression, it's important during the start of the case to have good communications with the anesthesia team, because you may want certain parameters. We may want a blood pressure in a certain range. We may want the patient to only get so much of IV fluids because we don't want any brain swelling. And the communication with the anesthesia team is typically started in the operating room before the patient arrives. And the communication with the anesthesia is ongoing, so it doesn't stop just at the start of the procedure, but in the beginning of the procedure is a very important time to transmit key information. We also typically use a neurology team to perform these microvascular decompressions. These neurologists they put tiny electrodes in your head and the arm and leg, and they monitor the brain signals and the nerve signals during the procedure. So you want to communicate with the neurology team about what nerves need to be monitored, where you're going to be doing the surgery, so they know where to go. They, meaning the neurologists, will also want to know where they can put potentially electrodes on the head, because remember, as a surgeon, we're going to be making an incision in the head. And if you place electrodes in the scalp where we need to make our skin incision, as you can imagine, that's not a good thing to have, and those electrodes will then need to be repositioned. So we try to do it correctly, get everything lined up with neurology through communication the first time. We also spend a fair chunk of time optimally positioning the patient's head on the operating room table. You want the head slightly above the heart. You don't want the patient in kind of a decline where they're lying on the back, the head facing down. You want the patient's head typically above the heart to minimize venous bleeding. And you also want to pad the extremities so there's no kind of peripheral nerve injury that can happen. In the OR setting, there's a lot of stuff going on. This picture shows at least two surgeons, one circulator, and then once you have all the electrodes in position, then we will be able to start the procedure here. You'll see in this picture here the microscope. It's draped and hanging down from the ceiling. You'll also see in the background an anesthesiologist there, and a couple of surgeons and the scrub nurse there. Planning the surgical opening of the bone. Typically, the skin incision is behind the ear, and we make a linear incision that we mark out with kind of a Sharpie pen, and that incision is designed to provide adequate exposure inside. So once you make the skin and bone opening, you should have the correct size opening to allow enough light from the microscope to get in, and allow enough space for you to get your surgical instruments into the space there to do the job. Medications can help facilitate brain relaxation. There are certain medications like mannitol and hypertonic saline that are designed to pull a little bit of water out of the body. The brain is like a sponge, and so if you pull a little bit of water out of that through medications, the brain is slightly smaller and more relaxed, and allows you to see the nerves that are located on the surface of the brain. I think it's important to realize that the trigeminal nerve is actually the part that we're looking at, while it's inside the skull, is outside of the brain. So you don't have to go through any brain tissue to get down to the trigeminal nerve. This is a couple of pictures in the operating room showing you where kind of the incision is marked out. It's you can see the incision is behind the patient's ear in both of these situations. There are two different patients. One where on the left side, we're going in on the patient's left, and on the right picture, we're going in on the patient's right. You'll also see on the picture on the left some little colored electrodes under some clear plastic. Those are the electrodes that the neurology team will put into the scalp to monitor the nerve activity and allow us to get important feedback when we're working around the trigeminal nerve. So now you've started the surgery, you've got the scalp and the bone open, and you're working under the microscope down to the trigeminal nerve. What are the next set of pieces of information you need to pay attention to? The trigeminal nerve is fairly deep compared to some of the other cranial nerves. So generally, the trigeminal nerve is not the first nerve you're going to see. So you can't get excited that the first nerve you see is the trigeminal nerve and that's where you need to go. You need to pay attention to the series of anatomic locations of these nerves to identify where the trigeminal nerve is. Generally, we see the seventh nerve or the ninth nerve first, and you have to kind of march up to find the fifth nerve. If there's any question, you can stimulate the nerve to determine whether or not that is a nerve that's the trigeminal nerve or a different type of nerve. The neurology team can tell you when you stimulate a nerve which nerve that is. So if there's any question, that's about to do. There generally are a number of veins that can obscure your view of the trigeminal nerve. I think it's important to fully identify, these veins, avoid injuring them while exposing the trigeminal nerve. So now you've found the trigeminal nerve, you're at the trigeminal nerve. The length of the nerve that you need to inspect to find blood vessels is only about a centimeter long, or about half of an inch. So it's a short segment. It's not a long segment of nerve that you need to inspect when you get down to the trigeminal nerve. It's a relatively short segment. Now it's covered by this membrane called arachnoid, which is like a clear saran wrap type of membrane. And it's important that you clear all of that off the trigeminal nerve so you can really fully assess the nerve. It's important to inspect the entire length of the nerve to identify all the blood vessels that might be contributing to a compression on the nerve. And you certainly, if you're going to do this surgery and go all the way down to the nerve, you want to make sure that you maximize the chance that the patient will have a great outcome with no residual pain. So you need to really make sure that the decompression is adequate. If you have more than one blood vessel, you will place the deeper cushions first. So the more shallow cushions are not obscuring your visibility of the deeper blood vessels. Arteries are one type of blood vessel. They're always packed off with these cushions to decompress the nerve and take the pressure off of the nerve. But veins can also be present, and they can either be packed off if they're larger vessels, or they can be cauterized and cut if they're smaller vessels. So surgical closure, you've now done the decompression. What do we need to be aware of? You want to inspect the anatomy now that you're done with the decompression, make sure everything looks good, that there's no evidence of any venous oozing that need to be taken care of. You want to really make sure when you put these cushions in and complete a microvascular decompression that you're not creating a new vascular compression, that you're not pushing the trigeminal nerve with your cushions into another blood vessel. So I've seen that happen a couple times. And you definitely can just replace one pain-causing vessel with another in that situation. There is a lining of the skull called the dura, which is a leathery closure. You want to make sure that's closed watertight. That prevents any CSF leak that can occur. And now we have these kind of sealant product, almost like a crazy glue that you can seal off any suture line to prevent any kind of CSF leak. Once the patient's out of the operating room, depending upon the medical institution, they'll either go to the ICU or to the recovery room. It's important there that the nurses that are managing the patients in either of these locations have experience with patients with both trigeminal neuralgia as well as surgery on the brain. We're going to want to do frequent neurologic checks. So every hour or so for the first few hours, we're going to assess the patient. We want to make sure as they're waking up that everything's working. And then also we also want to make sure that the patient knows what to look out for when they leave the hospital. And that is, make sure there's no swelling or redness along the incision line. What are the expectations in terms of how fast somebody's energy is going to come back? And what are the overall kind of expectations to return to work? So when patients are properly identified in their clinic and they have the classic symptoms and they have an MRI scan that shows a blood vessel on the nerve and they have a good surgery, the overall success rate for a microvascular decompression is 90%. So that means 9 out of 10 patients will have elimination of their pain, and the majority of those patients that do achieve elimination of the pain will have what I call durable pain relief, meaning lifetime potentially pain relief. So that's kind of what I wanted to cover today. I want to give everybody in this webinar the step-by-step thought process of how we think about a patient with face pain, going from the history, the clinical symptoms, to the classifying of the pain, to the steps in the operating room. So I want to thank you for your time. I'm going to try to take the questions that you guys may have. So if you have questions, you can type them into the question and answer box, and I will try to address these questions as they come in. Okay, so I'm going to start to take a look at these questions. The first question is regarding causes. Can a previous herpes zoster outbreak cause other facial pain ailments, such as geniculate neuralgia, occipital neuralgia, or is it only related to trigeminal neuralgia? So this is, again, having a viral infection of the trigeminal nerve, the same viruses that are the chickenpox viruses. And what the thought process there is that the viruses will they'll lie dormant in the trigeminal nerve up at the base of the skull. And they're opportunistic viruses, so they wait for you to feel fatigued or weak or tired, and then the viruses run down the nerves to the face, and they can cause these all like chickenpox pustules to appear. They're classically defined for trigeminal neuralgia. They're not really defined for geniculate neuralgia or occipital neuralgia. Geniculate neuralgia, there's really no superficial like skin source of the geniculate nerve. It's all deep in the throat. And the occipital nerve does innervate the back of the head, but I haven't seen any herpes zoster outbreaks in occipital neuralgia. So the next question is, how do you counsel patients about the presence or lack of trigeminal pain after the procedure? Should they expect complete resolution of pain or percentage reduction? So that's actually an excellent question, because when we talk about success, the 90%, what does that mean? So the 90% of patients that have success, there's either have no pain at all and are off all medications, or they have a dramatic reduction in pain to the point that either they require no medications despite the small level of pain, or they're on a much lower dose of medications and are no longer having any sedation from the medications. So the 90% doesn't include all 90% of patients aren't having complete pain resolution, but they're either complete or near complete to get into that category. Okay, the next question. Does Stanford clinics also treat trigeminal neuropathic pain? The answer to that question is yes, we do. We have a comprehensive facial pain program at Stanford. that consists of about 20 different physicians. And some of the physicians are neurosurgeons like myself that do these procedures. We have other physicians that are part of the neurology department or the pain group here at Stanford that are used to managing patients with trigeminal neuralgia through either medications or non-surgical procedures. We have ear, nose, and throat doctors. We have dentists. We have radiologists. So we have a comprehensive facial pain program, and trigeminal neuropathic pain is something that is generally more managed by medications, and those patients are typically seen by our neurologists and our pain clinic physicians in our facial pain program rather than undergoing a surgical procedure. But you can see how important it is to try to figure out which category of pain you're dealing with, because that will influence even how the referral to the facial pain clinic will be triaged. So the next question is, will there be a webinar addressing the less common types of trigeminal pain, such as MS and their treatments? That's actually an excellent topic. I think it would be certainly worthwhile to address kind of the less common types of trigeminal pain, because we may think of them as less common, but I probably see, 5 to 6 MS trigeminal neuralgia patients every half a year or so. So they're not as uncommon as one would think. And I think they're kind of a underserved kind of group of patients, because a lot of trigeminal neuralgia doctors will not really, they don't see a lot of MS type of trigeminal pain, so they don't know how to manage it appropriately. But that would be definitely a great topic for an upcoming webinar. The next question is, when taking trauma into account in your history and considering scar tissue, is there a time period in which you would rule out prior trauma as a potential cause, or would that go into your differential diagnosis regardless of how long ago the trauma occurred? So when you have a trauma to the trigeminal nerve, they're generally, you can have several different phases. The first phase is the acute trauma that happened. Your nerve was injured, it was swollen, it was, it suffered some pressure of an injury. So that can cause pain itself. Now, then the nerve starts healing. The pain may start to get better, but as it heals, it's never as pristine as it was initially. So scar tissue, which is your body's natural way of healing, the scar tissue can start to develop around the nerve, and the scar tissue can create some irregularity or lack of normal physiologic function of the nerve. It's no different than if you fractured your ankle. Once it heals, you may still have some intermittent discomfort, the gimpy ankle type of thing, because even though they quote unquote heal, there's some scar tissue that is left, left a deficit there. So once the scar tissue appears and is laid down and can impact the nerve, then it can pretty much be impactful from then on out. Scar tissue is fairly static; it doesn't change over time. So if you start to have pain from some scar tissue, it may be irrelevant if the trauma was a year ago versus 10 years ago. The next question is, I have GPN, which I'm assuming they're meaning glossopharyngeal neuralgia, but also have infrequent stabbing eye pain and numbness along my jawline. Would those two symptoms be trigeminal neuralgia and not glossopharyngeal neuralgia? So certainly the eye pain is not glossopharyngeal neuralgia. That is likely to be involving the trigeminal nerve. And the same thing about numbness along the jawline. I assume you're talking about along the mandible, the mandibular bone. That would be trigeminal nerve distribution, not the glossopharyngeal nerve distribution. So this would be a good example of how a patient can have more than one type of pain going on that can cloud the picture, and that can create a situation where if you're really trying to pin the blame all on one nerve, it may be difficult if there's more than one nerve. So the next comment, thank you. I had a MVD surgery. I guess this was supposed to be one of my patients 18 years ago. I'm still essentially pain-free. So I have 18 years of pain relief. This shows about the durability of this treatment. She says, I have occasional flare-ups in the springtime, but sounds like they're not even on any medications for that. I later developed a CSF leak on the other side of my face. Could they be related? So if the leak is on the other side of the face, it's not related to your trigeminal neuralgia or the microvascular decompression surgery. So they should not be related in terms of answer that question. Next question. My trigeminal neuralgia is caused by veins and not arteries, so decompression is not recommended. What are your thoughts about Gamma Knife? So first of all, for this patient, the understanding is veins can still cause trigeminal neuralgia, and oftentimes a microvascular decompression can, more often than not, still be beneficial in achieving pain relief. The only comment, a couple of comments we need to make about this is I'm presuming this call about veins versus arteries was made on an MRI scan. And I can tell you that MRI scans, while they can identify blood vessels pushing on the nerve, may not be able to identify every single blood vessel pushing on the nerve. Meaning, I've seen MRI scans that show 2 blood vessels pushing on the nerve, and when you get in there for the microvascular decompression, there's 3 or 4. So I wouldn't necessarily rely 100% on an MRI scan as being the only way to make a call here about, there's only a vein there. There could be an artery running parallel to the vein that make it look like a single blood vessel. And even if you have a vein, veins can cause trigeminal neuralgia. If you only find a vein in there, you either cauterize it or pack it off. And the only difference in outcome is that 90% that I talked about in terms of success rate drops about 70% if you're only dealing with a vein. Now, if you have an MRI scan, you don't see an artery or you just have a vein, or you see no blood vessels at all, then radiosurgery, which is the generic name for focused radiation, including a gamma knife or a cyber knife, those are all options for the patient. The radiation attempts to achieve its effect by injuring the nerve, by knocking out the pain fibers. So it's called a destructive technique. You're destroying the pain fibers to achieve the result, versus the microvascular decompression is considered a non-destructive technique. We are not trying to destroy the pain fibers in the nerve to achieve a result. We're just trying to get the pressure off of them. But you certainly can consider gamma knife or other forms of radiosurgery, such as a cyber knife, if you either don't want to undergo the surgery or if there doesn't look like there's a blood vessel on the MRI scan. One of the big difference between the microvascular decompression and the radiation, though, is that while I mentioned the microvascular decompression shows great durability in terms of long-term pain relief, a gamma knife or cyber knife, the radiation, the durability is much shorter. And why would that be the case? So if you do the radiation, even if the pain goes away within about 5 years, and half the patient, the pain comes back. And the simple explanation for that is that if you are going to achieve a objective on the trigeminal nerve by damaging the trigeminal nerve, we're shooting radiation at the nerve to damage it, or in a rhizotomy, they often use heat to damage the nerve to achieve the result. Your body does not know that that damage was done for a good, productive reason. It just sees, I got injured. And so it does whatever normal process was happening for an injury in your body, which is your body tries to repair the injury. So it goes along there and tries to reconnect the pain fibers. And at the 5-year mark, they're successful about in half the patients, so that the pain comes back. And so the primary downside about the radiation is that it is not the same durability one would expect with the as respect with the microvascular decompression. There's a question about laser therapy. I haven't done that, or so I'm not going to comment on that. I don't have any experience with that. There's another question about, as the pain evolves from type 1 to type 2 and beyond, is there a point at which a MVD is not appropriate? So this is a good question. So what I always counsel patients with type 2 trigeminal neuralgia is that the microvascular decompression will have a high chance of making the electrical shock pain go away, but a much lower chance of making the chronic achy pain go away. And so in a patient with type 2 trigeminal neuralgia, you remember the sharp electrical shocks are less than half of the total pain, and the achy pain is more than half of the total pain. And so in a patient with type 2 trigeminal neuralgia, is an MVD still appropriate if less than half the pain is electrical shocks? And the answer for the most part is yes, it is, for a couple of reasons. First is that the achy pain might go away. I mean, we're just saying it doesn't have the same high chance as the sharp electrical shocks. The second issue that I always couch it to patients when I'm talking about this is we'll say, look, we know you have achy pain, and we know you have also the sharp electrical shocks. If only the electrical shock pain went away, would you consider that a better outcome or better situation than you are right now? And the majority of patients would still say yes. You know, if you can get rid of electrical shocks, even if I'm left with the achy pain, that's still a better situation than I'm at right now. So in those situations, it still does make sense to do a microvascular decompression for type 2 trigeminal neuralgia. The next question, is there a possibility if someone does a CyberKnife, it increases type 2 pain while decreasing type 1 pain? So that's a similar type of situation. If you have both achy pain and sharp pain and you undergo the radiation treatment, it's possible we may make the sharp pain go away, but the achy pain is still there. So we're not converting sharp pain to achy pain. We're just leaving the achy pain potentially behind. And then the patient goes from having partial sharp and achy pain to all achy pain. It doesn't necessarily mean they're worse off, and oftentimes they're better off. The next question is about they're about some research that we're doing at Stanford about a drug using CSF fluid. This is being run by Dr. Lim, so you can certainly contact his office. His information is on the Stanford Department webpage, and his office would be able to tell you about this trial that we're potentially looking at. The next question is, if the offending vessel isn't obvious on the MRI scan, can it be visualized during an MVD procedure? And this is an excellent question, because back in the old days, meaning we didn't have good MRI scans, the quality of the MRI was poor back in the 1990s and early 2000s. The MRI scans would often come back as normal. We don't see any blood vessel, but then patients would have such classic symptoms, we would say, we're pretty sure there's a blood vessel there. And those patients would get an MVD, and almost all the time you would find a blood vessel there. So if a patient comes in with an MRI scan that doesn't have that Fiesta or the CISS sequences that I mentioned in one of the slides, the first step is to repeat the MRI and get those key sequences, get the correct sequences. This is, we're talking about whether or not to do brain surgery or not. So getting another MRI scan, it gives us the correct information, high resolution pictures is definitely worth it. Now, if we get that MRI scan with the high resolution pictures and we don't see any blood vessels, then you need to have a frank discussion with the patient saying, you could still do the MVD, and pretty good chance you're going to find some blood vessels that were not picked up by the MRI scan, or you want to try a non-surgical alternative such as the CyberKnife radiosurgery or gamma knife type of procedure, or the rhizotomy procedure. Those try to knock out the pain virus irrespective of whether there's a blood vessel pushing on the nerve or not. I have supratrochlear neuralgia on gabapentin, Botox. This never treat this. Yes, we do treat this. It's done by our neurology group. Surgery is not really appropriate for this diagnosis. It's not thought to be a vascular compression syndrome. It's typically treated by the neurologist with medications and the Botox, which it sounds like you're already having treatment for. Can I talk to patients that have had the MVD procedures? Yes, we do have groups of patients that are happy to talk about their experiences. Vo, who's our coordinator, and whose number is on the slide there, that telephone number at the bottom, could help potentially facilitate that. Generally, we rely on the generosity of prior patients that have had a microvascular decompression to where their time and their ability to talk to other patients. But these patients have all walked through the same steps that you've been walking through, and they can certainly tell you their experiences and in terms of how they've done with the microvascular decompression. The next question is, speak briefly on Teflon versus other barriers. So when we put these, I refer to them as cushions. They're actually, they look like miniature cotton balls, but instead of cotton, they're made out of fibrillary Teflon. So it's not the Teflon in the frying pan, but they look up like those. They look like those eye makeup pad removers, just on a very microscopic scale. They're about the size of a white grain of rice. So we use Teflon because it's not absorbed by the body and it's inert. And it's been the treatment of choice in terms of material for microvascular decompression for decades. Now, the next question, I've been diagnosed with trigeminal neuralgia 3 years ago. I'm dealing with it for 6 years. So it sounds like for the first 3 years, they didn't have a diagnosis. And then the last 3 out of the 6 years, they finally got a diagnosis. Medications and injections haven't worked. One of the injections caused some numbness in my face and mouth. I made a lidocaine injection in March, and it worked best, but it was only effective for a couple of hours. Neurologist is contemplating a longer-lasting lidocaine procedure. So the story here is a little bit, I mean, it's obviously only probably a snippet of what's a longer history going on here. If this is really trigeminal neuralgia, the question is, what did the MRI show? They talk about medications and injections, but there's not a discussion of whether there was a procedure that was done or discussed. So a little bit hard to know what's going on here. If the standard trigeminal neuralgia medications didn't work, that actually is a little bit of a red flag that something may not be really matching true trigeminal neuralgia here. So I'm not going to be able to give a perfect answer to this question because I think there's a lot of details that are missing. The fact that the medicines didn't work and you're considering lidocaine injections makes me think that this is not one of the type 1 or type 2 trigeminal neuralgia treatments. So they're promising new treatments for trigeminal neuralgia, stem cell treatment, repetitive transcranial magnetic stimulation. So the short answer to this is yes, people are trying a bunch of different things because, as you can imagine, trigeminal neuralgia is such a debilitating disease. None of it so far is affected the mainstay of the treatments, which are the microvascular decompression, the radiosurgery, and the rhizotomy, which uses heat, and a glycerol injection, which uses alcohol to damage the trigeminal nerve. Is a pain management group located in Redwood City? I presume you mean the facial pain group here, as opposed to the general pain management group that treats back pain and hip pain. So the facial pain program is primarily based around the Stanford Neurosciences building, which is a building down in Palo Alto, close to the main hospital. It's a 4-story building, 5 counting the basement, that has all the neurospecialists in there, including the neurosurgeons, the pain specialists that manage facial pain, the neurologists that manage facial pain. They're all located in that neuroscience building. Next question, which rhizotomy do you feel is most effective? Balloon, glycerol, etc. So rhizotomy procedures in general achieve their result by damaging the nerve. It's a little bit of this, you're damaging the nerve no matter what you're doing. So almost all of them have the same initial efficacy, which is assuming it's type 1 or type 2 trigeminal neuralgia, very high, 85, 90%. The challenge with the rhizotomy is, again, your body's interpretation of the damage. Your body feels the damage was done for a reason that it doesn't understand. It tries to repair the damage. The pain fibers get repaired. Sometimes the pain fibers get repaired, but get repaired incorrectly. And then that can cause other types of pain that are not true trigeminal neuralgia. Remember that one category of pain on that facial pain classification I showed you was trigeminal deafferentation pain. That's pain from a prior procedure. So you could have a rhizotomy procedure that makes the trigeminal pain get better, but leaves you with other types of face pain. And that's the challenge when you use a destructive procedure. You know, if you're going to deliberately break a bone in half and then try to get it to heal, it may not heal correctly. That's why I think the focus tonight I wanted to make on the microvascular decompression, because that's the only non-destructive procedure that we're talking about tonight. Next question is it usually the case that bilateral compressions have poorer outcomes and pain relief with microvascular decompression? So I think this is more what happens if you have bilateral trigeminal neuralgia. I usually, in those circumstances, ask the patient two questions. Which side did the pain start and which side is the pain worse? And hopefully they're the same. And then I do a microvascular decompression just on that side. Oftentimes, the other side of the face pain will get better just by doing the microvascular decompression on one side. There's some crosstalk at a trigeminal nerve nuclei level in the brain that may be accounting for part of that. But for whatever reason, if you do a one-side microvascular decompression, there's not 100%, but a reasonable chance you may see some improvement on the opposite side. If that doesn't happen, but the patient has a good result on the first side, you can consider microvascular decompression on the second side. I've done that in some patients as well. The next question is, if somebody is managing their pain without medication for a number of years, what is your recommendation regarding the frequency of follow-up visits with neurologists and the benefit of seeing them? It seems like, unless I'm on the medication, the recommendation is carry on day to day until it gets worse. It's been many years since the last neurology appointment, and I don't know if I'm missing something by not getting it checked out more frequently. So I think the answer to this question depends upon what type of neurologist was managing your trigeminal neuralgia pain. And by that, I mean, there are a number of great neurologists there that are generalists. They're general neurology specialists. They see a variety of types of neurologic disorder, from cerebral palsy to Alzheimer's, to now they're seeing, you for trigeminal neuralgia. That's different from a neurologist or pain specialist that truly has a focus on trigeminal neuralgia and face pain. And if you've seen a general neurologist, they may not, and they've maxed out what they're able to do for you, you may not have much of a benefit. But if you've really haven't seen a specialist in neurology that specializes in face pain, that's probably worth a consult, just to make sure that there's not something that you could be trying that you haven't tried before. The next question is, has anybody during a microvascular decompression surgery developed a stroke? That's a theoretical risk. It's very, very, very unusual, because you do the surgery under a microscope, so the trigeminal nerve is as big as your arm and the blood vessel as big as your other arm. So you have a very good chance of seeing blood vessels at surgery. So it's very rare that you would run into a problem that you would create a stroke. Super infrequent, less than 1%, I would say. Does radiation like the gamma knife make later MVD more difficult? Yes and no. There's not a lot of scarring. So on one hand, that doesn't make the microvascular decompression more difficult after radiation. But on the other hand, if you have gamma knife and it doesn't work, that actually may point to away from you have the correct diagnosis of trigeminal neuralgia. And therefore, doing an MVD, if you don't have the correct diagnosis of trigeminal neuralgia, may have a lower than 90% success rate. So you can certainly do an MVD after a gamma knife, but if you're failing a gamma knife procedure, it's giving us some clues that maybe this is more than just standard trigeminal neuralgia pain. It says, I had my MVD at Stanford. After MRI showed artery touching my trigeminal nerve. I was pain-free for several weeks, but the trigeminal nerve type 2 pain, which is, I guess, the achy pain, returned at baseline. I had a rhizotomy, which also didn't work very well and caused some numbness. Is there anything besides medications? I have currently an appointment for a peripheral nerve stimulator, but insurance is complaining about paying for it. I'm already on high dose of medications, but the trigeminal type 2 pain has gotten severe. I also have occipital neuralgia. So again, this is a complex situation. Multiple neuralgias going on, multiple prior procedures. The fact that you're talking about a peripheral nerve stimulator means you're already well beyond all the basic interventions to more advanced interventions. There these spinal cord stimulators. These peripheral nerve stimulators are very uncommon, which is why insurance companies often get confused. I think obviously if you're talking about a peripheral nerve stimulator, you're talking with someone that's very sophisticated, because there's not a lot of physicians that will understand the nuances among a peripheral nerve stimulator. So I think that from where you're describing right now, that may be a good place to focus the efforts on right now in terms of the peripheral nerve stimulator. The next question is, it normal to feel your body feels warm after each attack? That's something that I have had some patients describe to me. I'm not sure how common it is, but it's certainly something I have heard of before. The next question is a Fiesta MRI scan specific for trigeminal neuralgia, or can it find other types of neuralgias like geniculate neuralgia? And if not, what are the best types of scans? So an MRI scan will show you details of neuralgia from blood vessel compression inside the skull. So that would include trigeminal neuralgia, possibly geniculate neuralgia, glossopharyngeal neuralgia, all those. Those are blood vessels pushing on nerves inside the skull. Occipital neuralgia is often the nerve getting pinched out in the neck between the bones of the spine. And so doing a Fiesta MRI scan, looking at blood vessels and inside the brain, the skull itself, it's not going to include the area. It's not going to give us the same visibility in the area where the nerves exit the neck. So it's occipital neuralgia, most things you may not be able to see well on an MRI scan. Next question. I have a good response to gamma knife earlier this year, but I have to consider what to do when the pain returns. Is it true you can only have gamma knife twice? So 2 times is not a problem. 3 times is starting to become a little bit fairly rare. There's only a couple pieces of medical literature that talk about using gamma knife 3 times, just because of the rising incidence of facial numbness. So generally, I would say if you've had gamma knife twice and yet the pain recurs again, if you're in that category, before taking a 3rd radiation procedure, I would have a frank discussion with your doctors about the other choices at that time. Next patient, MVD worked for 18 years, but then the pain recurred. I had a rhizotomy, which provided only 1 year of relief or so. MRI does not show a bending vessel, which their opinion or options. So again, this is a good example of the durability difference. Microvascular decompression worked for 18 years with the rhizotomy using the heat or the balloon or the glycerol, worked only 1 year. So That's the perfect example of the durability difference there. If the MRI does not show an offending vessel, you could continue to repeat rhizotomy. You could try the radiosurgery. I think that has a less chance of abrupt healing as the rhizotomy. The radiation treatment may give you a little bit better durability. You can always consider the option of a repeat MVD, even though the MRI doesn't show an offending vessel, under the off chance that maybe one of the vessels there before that wasn't symptomatic is now symptomatic. You don't mention whether or not you have this CISS or Fiesta sequence. I think that would be important to get no matter what. And you would need that anyway if you were going to consider a radiation option, because that's a big part of the radiation. So next question was, I have MS and did not have type 2 pain until after CyberKnife earlier this year. Can CyberKnife cause type 2 pain? Generally, the type of pain that you can get, this deafferentation pain, is more of an achy chronic pain. So if that's the type of pain you're having, that theoretically could be related. Alternatively, the pain that you're having may be related to, again, the healing of the nerve after the radiation, and if that heals with some irregularity, that can cause some type of achy pain. So hard to really answer in more detail than that with just the history, but it depends really what you're classifying as just type 2 facial pain. Next question: I've had trigeminal neuralgia for 12 years. On the max dose of the gabapentin oxcarbazepine caused SIADH, which is making a lot of urine, your body dumping fluid. Would Stanford do an MVD or radiation treatment or something else? So no mention of the MRI scan. I would start with a good MRI with a Fiesta sequence to study that, to see if there are blood vessels along the nerve. If there are, it's microvascular decompression. If there are not, then you consider a radiation treatment. So to answer your question, what would Stanford do? Is we would need to see kind of what the MRI showed to be able to fully answer that question. The second to last question: I started feeling electroshocks after dental procedures 2.5 years ago. Is it possible that the dental procedure could have triggered it? Yes and no. A lot of times dental procedures cause some chronic type of pain in the face that's not related to trigeminal neuralgia, but there's certainly some situations where having a dental procedure irritates the trigeminal nerve and kind of gets it active and gets it fired up. So the answer to your question is yes, it's possible depending upon the details of the circumstances. Next question: is there a high number of patients with migraines as well as trigeminal neuralgia? The answer to that question is yes. Seems to be a reasonable correlation between migraines and trigeminal neuralgia. Perhaps maybe if there's an underlying stress as an underlying connecting factor, if you're suffering from a lot of facial pain, you don't know when it's going to occur, you're very anxious, that can create that anxiety, and anxiety creates this tension and headaches start. So there may be a way that they're actually connected that way. And then the last question before we go is: does Gamma Knife make a subsequent MVD more complicated? And I think this was what was asked before, is that radiation doesn't necessarily make an MVD technically more complicated. There can be a little bit of scar tissue, but typically it's not a lot. But if you have Gamma Knife and it fails, you are sub-selecting yourself out to a group that's less likely to have a good outcome. Just because the fact that the Gamma Knife, if it doesn't work, and then now you have to do an MVD, the fact that the Gamma Knife didn't work gives you some predictive value that that maybe this is not quite trigeminal neuralgia. Okay, everybody, I think we ran over just a little bit, but those are all great questions. I hope that you've enjoyed this presentation, and certainly if you have any additional questions, feel free to contact us, either call or email. We'd be happy to try to help to everyone to the best of our ability. Thank you, everybody. Have a great evening. Take care.